In this slide set, we will be discussing the symptoms associated with stable angina. We will also define the CCS angina classification, precipitating factors for angina, and distinguish stable versus unstable angina. Again, we will work with our case that we also used in the introductory slide set. So what are signs and symptoms? Well, signs are the objective evidence for the presence of angina or CAD, but this slide set will be talking about symptoms, which is the subjective evidence for indicating the presence of angina or CAD. We discuss angina symptom presentation with the following acronym called PQRST. In fact, this acronym can be used with any type of condition where a patient presents with symptoms, particularly pain symptoms, but any symptoms. So it's a way of categorizing how to think through the symptoms the patient's presenting with. So we will be going through each of these individually. We will start with the P. For the P, there's two factors: precipitating factors and palliative or relieving factors. Precipitating factors would be things that are either drug or disease related that might precipitate or bring on an episode of angina. So I've listed here some drug related factors and disease related factors, and these are all related to the oxygen supply demand imbalance. So you need to understand that from the last lecture series to understand how these precipitating factors can impact angina. For example, we talked about anemia in the last slide set, how anemia can decrease the oxygen content of the blood, and this can decrease the supply of oxygen. So this is one way that that can affect the symptoms of stable exertional angina. Another situation could be such drugs such as thyroxine or sympathomimetics, or any drugs that can increase the heart rate or blood pressure. Some of those medications can increase the oxygen demand, and then again that can throw off the imbalance between oxygen supply and demand. So that's precipitating factors. Palliative factors, otherwise known as relieving factors for stable angina, would be if the patient's symptoms go away when they rest for a couple minutes, it goes away, or also if they take sublingual nitroglycerin, they usually have relief within a few minutes, or if the stressor is removed, so any of these precipitating factors is removed, then the patient actually gets better. This list is not completely comprehensive, but this gives an idea of the major precipitating factors and the major palliative factors. The next is Q, or quality of symptoms. As I mentioned previously, it's a misconception that angina always means chest pain. Patients don't always have that Hollywood type chest pain where they grab their chest and then they fall to the ground. There's many different ways it can present, and some of these are listed here. Particularly for women, they do present a little bit differently. They tend more to have shortness of breath or a feeling of constriction in their chest. And also elderly people tend to present a little bit differently. They tend to present more with non-specific symptoms. And patients with diabetes have decreased pain sensation, and they may present, in fact, with very few symptoms at all. But in fact, you can have pain, a burning, a tightness, a pressure, or a weight on the chest. Any of these can be signs of angina, and we need to be aware of the atypical presentations. Other symptoms that patients may present with less commonly are ones that are listed here. Sometimes people present with ischemia, meaning decreased oxygen supply to coronary artery, and it's not an acute situation, but they present with some of these, which can turn into an acute situation. In terms of the R, it signifies two things: region and radiation. So where the angina symptoms tend to happen are listed here. There's quite a few of them, but it tends to be over or near the sternum, so the center of the chest, and we often call it substernal if patients feel it beneath their sternum. It's between the stomach, the epigastrium, and the pharynx, so around the neck. It's within that area. Sometimes it can be going to the left arm, rarely to the right arm. Sometimes people feel it in the lower jaw, especially the left side, or in their upper spine, or in between their shoulder blades. They can feel that, especially on the left side. Those are the typical locations. The radiation tends to go to the left side or to the jaw, very rarely to the right side. So typical angina tends to have this retrosternal or substernal location. We often call it retrosternal chest pain, even though it's not always pain, which can be abbreviated as RSCP. You might see that abbreviation. And typical angina is provoked by an activity or a stress, and it's relieved by rest or nitroglycerin. So if it has all three of those features, it's very typical angina. It's more atypical if it only has one or two of those features. And then we question whether it really is angina or some other indication for having chest pain or angina symptoms. So on this slide are features not characteristic of angina or myocardial ischemia or an imbalance between the myocardial oxygen demand and supply. If there's a very sharp pain, especially brought about by breathing in or coughing, if a patient can localize the pain with the tip of one finger, especially near the stomach or around the apex of the left ventricle. If it's more in the middle or lower abdominal area, or if it's produced by movement or palpation or touching the area. If it's very, very brief and goes away very quickly, and if it radiates to the lower extremities. So these are characteristics not related to typical angina, and other conditions need to be considered. And it's very important that pharmacists do understand how this presents, because patients will often come to the pharmacy with some of these symptoms, and you need to be able to triage the patient to advise them whether this is something that needs to be considered to be angina, whether it's something they can take an OTC medication for. Often patients will come in with GERD type symptoms, and you need to determine whether it is very characteristic of GERD or reflux as opposed to something that could be an angina presentation. So the S is severity of angina, and it is defined by the CCS, or Canadian Cardiovascular Society classification. This is the standard classification for angina. It goes from class 1 to class 4 in an ordered fashion. Class 1 is asymptomatic with ordinary activity, but could be with more than ordinary or very strenuous activity. And class 4 is basically symptoms at rest or not being able to carry on any activity. Class 2 is slight limitation. Class 3 is marked limitation with ordinary activity. And on these next slides, I give you some more examples. So class 1 we talked about. Class 2 gives you specific criteria in terms of when the patient might get symptoms. So if they are able to walk more than 2 blocks before they get some angina symptoms, or climb more than 1 flight of stairs before getting angina symptoms in normal conditions, this would be class 2 symptoms. Class 3 would be if they can walk less than or equal to 2 blocks, or less than or equal to 1 flight of stairs. That would be class 3 symptoms. And we've already talked about class 4. The T stands for temporal pattern, so the duration or the time that the stable angina lasts. Typically, it's usually less than 5 minutes, but it can range from half a minute to 15 minutes. If it's more than 15 minutes, certainly if it's at rest, we are concerned for an acute coronary syndrome. So unstable angina is one of the types of acute coronary syndromes, and we'll be talking about that tomorrow. The definition of unstable angina itself is as follows. It's angina that's at rest and prolonged, usually greater than 20 minutes in duration. It is new onset, so it started in the last 2 months, and it started at a pretty severe level, so a CCS class of at least 3, so that means their activity is quite limited, and it's not getting better with therapy for angina. Or the other situation of unstable angina is something that where a patient had angina before, and then it distinctly becomes more frequent, longer in duration, or it is lower in threshold. That means that it increased by at least one class to CCS class 3. So say they started at class 1, and all of a sudden they're up to class 3 angina. So that's something we sometimes call crescendo angina. So it's kind of going up in nature and getting worse. And it's important to understand and determine when someone has a decrease in their capacity that they might be heading towards having unstable angina. So we need to differentiate stable angina from unstable angina, and that is summarized on this slide here. It can be summarized as the difference in the duration, shorter versus longer, whether it's at rest, unstable is at rest, and stable angina is completely reversible and predictable versus unstable angina not being the case. So these are the major distinguishing characteristics between the two. Next, we'll go back to our patient case. We can see the patient case on the left-hand side here, and I'd like you to look at the case and answer the following questions. What symptoms does our patient have that indicate angina? Think of the PHRM and go through those. And specifically also, what is the patient's CCS classification? So you'll be going through the S for the severity to determine their level of classification. And I'd also like to note that we'll be going through this in class, as well as the initial slide set. We'll be going through the patient's risk factors. And finally, that there is also a Word document that contains a lot of this information, as well as some more detailed information that is also posted on Blackboard that you will also be responsible for.